Hello everyone. The journal topic we are going to discuss today is endovascular therapy for acute stroke with a large ischemic region. This study was published in NEJM in April 2022. Before going to discuss the study, we should have some knowledge about few scoring systems used in this study. So first one is the aspect score. This score is used for segmental estimation of the middle cerebral artery vascular territory. So where the MCA territory is divided into 10 region, M1 to M6, caudate, putamen, internal capsule and the insular cortex. So here the initial score is 10 when there is no infarct in any of the region. So as the infarct develop in a specific region, so 1 point is deducted from the initial score of the 10. So it means higher the score, the lesser is the infarct area. Second one is the National Institutes of Health Stroke Scale. So this is a tool used by the healthcare provider to objectively quantify the impairment caused by the stroke. So here the score varies from 0 to 42. 0 means there is no stroke symptoms and more than 21 is labeled as severe stroke. Modifier Rankin score. This is used to measure the degree of disability in patients with stroke. So here the score of 0 means no symptoms at all. As the score increases, the degree of disability and dependency also increases. And a score of 6 means dead. So we know that endovascular therapy is considered as one of the standard treatment for large vessel occlusion stroke, involving the vessels like the internal carotid artery, the M1 segment of the MCA, with an aspects value of at least 6, and when there is a mismatch between the ischemic core volume and the volume of the perfusion delay area. So till now, all the randomized controlled trial for endovascular therapy done, they included patients with an aspect value of at least 6. There is no randomized controlled trial done for a lesser aspect value of less than 5. So this is a systematic review and meta-analysis of trials, imaging and outcome measures for large core stroke thrombectomy. So here this meta-analysis includes only the observational studies, including aspects value of 5 or less. So what they found that EVT is associated with improved functional independence and lower mortality at 90 days without significant increase in the symptomatic intracerebral hemorrhage for patients of lesser aspects value. So here the research question is, does endovascular therapy in addition to the standard medical care improve the clinical outcomes in large strokes in comparison to the medical therapy alone? So this study was a multicentric which was conducted in 45 hospitals in Japan, and open label parallel group randomized clinical trial which was conducted for over a period of November 2018 to September 2021. The inclusion criteria are adult patients of age group more than 18 years with a diagnosis of acute ischemic stroke with baseline the NIHSS scoring of more than equal to 6 at the time of randomization, the pre-stroke modifier Rankin's score of 0 to 1, with a confirmed extra or intracranial ICA or M1 MCA confirmed by CT angio or MR angio, aspect value of 3 to 5 on CT or diffusion wetted MRI. So here they did not evaluate the aspect value of less than equal to 2 because they the aspect value of less than 2 means they have extensive infarction and are very unlikely to regain the functional independence. And again, inclusion criteria are randomization can be finished within 6 hours from the last known well time or 6 to 24 hours from the last known well time when there is no hyperintensity on the flare image, which is in accordance with the early ischemic change on NCCT or the diffusion wetted MRI. And the EVT can be initiated within 60 minutes from the time of randomization. Exclusion criteria are when there is clinically significant cerebral mass effect with midline shifting, or there is acute ICH on CT or MRI, There is high risk of hemorrhage like thrombocytopenia with a platelet of less than 40,000, INR of more than 3. If patient is known allergy to the contrast agent, pregnant patients, and when there is a clinical evidence of chronic occlusion of the vessels. Randomization was performed to balance the trial group assignments on the basis of age, interval between the patient last known to be well and the time of hospital arrival, whether less than 2 hours or more than 2 hours, the NIHSS score at the time of admission, whether it is severe or not, less than 21 or more than equal to 21, and use of altiplase. The trial group assignments were not concealed from the patients or the treating physicians. Patients were randomly assigned in a 1:1 ratio to receive endovascular therapy with medical care or medical care alone. The method of endovascular therapy include are stent retriever, aspiration catheter, balloon angioplasty, intracranial stent or carotid artery stent. Patients with indication of altiplase were treated according to the Japanese guideline, where the dose of altiplase used was 0.6 mg per kg, which is lesser than the standard dose recommended by the American Heart Association, that is 0.9 mg per kg. But other aspects of the medical care in both the group were in line with the guideline from the AHA. The clinical assessments were performed at baseline, post randomization at 12 hours, 24 to 72 hours, 5 to 9 days, or at the time of discharge, and again 60 to 120 days. So, what are the clinical assessments? They were like the patient characteristics, medical history, vital signs, lab data, medications used, then the MRS and the NIHSS score. In the endovascular therapy group, TC grade 2B, that is the thrombolysis in cerebral infarction, is used as a threshold for successful recanalization. So where the grade 2B means when there is antegrade reperfusion occurs in more than half of the previously occluded target artery ischemic territory. Then follow-up imaging was performed 24 to 72 hours and 5 to 9 days after randomization or at the time of discharge. Those imaging data were submitted to the central core lab and independently they were evaluated by an imaging evaluation committee. Coming to the outcome measures, the primary outcome was a moderate functional outcome, that is the MRS of less than equal to 3 at 90 days. Secondary outcomes are good functional outcome at 90 days, excellent functional outcome means MRS of less than equal to 1 at 90 days. Then ordinal shift across the range of the MRS towards a better outcome, and improvement of more than equal to 8 points on the NIHS score at 48 hours. Safety outcomes measures are symptomatic ICH, any ICH within 48 hours, death within 90 days, recurrence of ischemic stroke within 90 days, and decompressive craniectomy within 7 days. So definition of symptomatic ICH here is when there is clots in at least 30% of the infarct area with space occupying effect and worsening of the NIHSS score of more than equal to 4 points within 48 hours. So the sample size calculation was done. So a previous from the previous registry observational study done by the same researcher group, where they found that when EVT is used for acute large vessel occlusion with the aspect value of 3 to 5, the MRS of 0 to 3 at 90 days was 37.7% in the EVT group in comparison to 12.5% when there is no EVT. So from there, the adjusted odds ratio came out to be 3.42 in favor of the EVT group. Because that registry was observational, so 20% of the effect was deducted and assumed odds ratio for this RCT was found to be 2.7. So on the basis of these assumptions, 81 patients were needed for each trial group, and assuming a dropout of 15%, the required sample size was 191. Then considering the potential withdrawal of the consent, the final sample size was came out to be 200 patients to provide the trial with a 90% power to show the superiority of the EVT over the medical care at a two-sided alpha value of 0.05. Coming to the result, so flow of the patient to this study. So total 235 patients were assessed for eligibility, out of which 32 were excluded. Finally, 203 were underwent randomization into two groups, 101 to the EVT group and 102 to the medical care group. One patient withdrew consent from the EVT group, so 100 were included in the full analysis population in the EVT and 102 in the medical care group. Then after adjudication, 6 more were excluded from the EVT group and 8 from the medical care group. So finally 94 were included in the per protocol population for both the group. So the baseline demographic and clinical characteristics of both the group were similar. The mean age was 76. 54% of the patients were male patients. The median MRA score was 0. Median NIHS score was 22. The median aspect value was 3 for the EVT group and 4 for the medical care group. Use of altiplase was only in 26.7% in the EVT group and 28% in the medical care group. The median interval between the time of the stroke onset and hospital arrival was 190 versus 170, and 35.6% of the patients were included or were came to the hospital within 2 hours. The interval between the time of stroke onset and time of randomization, the median time was 229 minutes, out of which almost 55% of the patients were randomized within 4.5 hours period. For the EVT group, the median interval between the time of the stroke onset and puncture time was 254 minutes, and time of reperfusion was 308 minutes. 86% of the patients in the EVT group they achieved the TC grade 2B. So the primary outcome, that is the MRA score of 0 to 3 at 90 days. So it was found in 31 patients in the EVT group versus 12.7% in the medical care group, which was found to be statistically significant. The secondary outcomes, none of the secondary outcomes were found to be statistically significant, like the MRA score of 0 to 2 at 90 days or ordinal shift across the range of the MRA scale, then improvement of more than 8 points on the NIHS score. So all these were similar in both the group. Coming to the safety outcomes, the symptomatic ICH within 48 hours developed in 9% of the patient in the EVT group and 4.9% in the medical care group, which was similar, not statistically significant difference, but development of any ICH within 48 hours was higher in the EVT group, that is 58% versus 31.4%, which is statistically significant. Then other safety outcomes like death or recurrence of cerebral infarction within 90 days or need of decompressive craniectomy within 7 days were similar in both the group. So in this trial, the percentage of patients with large ischemic region of acute stroke as measured by the aspect value of 3 to 5 who had a good functional status at 90 days with respect to the primary outcome was significantly higher with the EVT plus medical care group in comparison to the standard medical care group alone. Overall, there were significantly more ICH in the EVT group than in the medical care group, but the difference in the percentage of patients with symptomatic ICH was not significant. Coming to the strength of the study, so this study addressed an important clinical question that has implications for patient outcome as well as resource utilization. The study was multicentric, which increases its external validity. It has a patient-centered primary outcome as opposed to a disease-oriented outcome. Randomization was adequately performed and baseline characteristics were well balanced. Coming to the limitations, this is an unblinded study where the patient treating clinicians were not blinded, so which may add significant bias in the primary outcome as well as the safety outcomes like symptomatic ICH. Though It was a multicentric, but it occurred in single country, so which can limit the external validity. There is subjectivity to MRS calculation, so which limit the validity of the data. And it is again unclear how the patients were evaluated at 90 days, because this is done by the phone interview, which again can introduce bias. Relatively low use of altiplase among the enrolled patients might have altered the outcomes in both the groups, and which could be a disadvantage to the medical care group. Low dose of altiplase used in comparison to the standard dose can affect the primary as well as the safety outcome. So to conclude, this study showed that patients with acute stroke with large vessel occlusion and a large ischemic region, the functional outcomes at 90 days were better with endovascular therapy and medical care group in comparison to the medical care group alone. But endovascular therapy was associated with increased incidence of intracerebral hemorrhage. Thank you.